Okay, why don't we get started? Welcome everyone to our season finale of the 2024-25 LHS or Learning Health System seminar series. I'm Salmia Mayapin. I'm manager of the Learning Health System here at Women's College, and it's great to see more of you joining our final session of the season. So we have a special treat today. As you may have seen from the calendar invite, we've chosen to feature our three different working groups. And as you can see here, we have a piece on our LHS collaboratory. So speaking to the structure and function, we'll be looking at our patient-reported outcome measures, as well as our LHS data ecosystem. So all very different, and looking forward to sharing those updates with you all. Before we get started with our mini presentations, just want to make sure everyone's on the same page and do a quick recap of what we mean by a learning health system in a nutshell. So this is essentially a cycle of taking research findings, bringing them back into patient care, and then back again for more exploration on how we can do things better and also in a faster way. And we use the term research, but it could also be quality improvement. It also could be education. It's essentially how are we closing the loop from knowledge back to practice. So learning health systems are driven by data and evidence. They're patient-centered, focusing on individuals, families, and communities. And at Women's, we really want to foster that workforce culture of curiosity and engagement. So where we're continuously thinking about and reflecting on how we can do things in a different way, in a better way, and of course, affect improvements to patient care. We also recognize that we are nimble and have a solutions-oriented mindset, and of course that just-in-time changes and small improvements can actually make a big impact. And yeah, just at the heart of it is that cycle, and you're going to see some of these themes woven through the presentations today. So really taking that data from practice, converting that to knowledge, and then applying that knowledge back to practice. We use the word practice, but it could also mean performance, so even in non-clinical areas, and we're hoping to show more of that in the future. So just to show everyone just how things are structured when it comes to the LHS initiative, we have a steering committee. It's chaired by our VP of Academics, Dr. Rulan Parekh, our head of surgery, Dr. David Urbach, as well as myself. And it's a very multi-professional group. We have scientists, we have clinicians, we have operations leaders, as well as experience advisors, just to name a few. And so that steering committee, from there, we branched off into three different strategic working groups, and that's who you'll be hearing from today. And you'll see on the far right, we also have some future ideas for pilots, so stay tuned for that. And of course, everything we do, we make sure we align this to the healthcare revolutionized strategy. So you'll see hints of that as well. You'll see that academics is one of the key enablers of these key strategic directions. So when we talk about PROMs, for instance, it's really around driving that precision healthcare. When we talk about the Learning Health System Collaboratory with the toolkit, even with the data ecosystem, a lot of that is around reimagining the health system with and for patients. And of course, cutting across is health equity. One last thing before I turn it over to our first presentation, just want to do a quick shout out for the Day of Excellence in Academics. I believe many of you were able to attend and participate in some way. There's a link here to just read a quick recap done by Strategic Communications. And the reason I mention this is it's not just a single event that happens once a year. It's more than that. It's really, we see it as a vehicle for driving that learning health system vision, something that involves not just research, but quality improvement, education, and done across the board. So one stat I really like to share these days is that when we look at the 67 posters we had, 29% of these authors self-identified as a researcher, so less than a third. The rest were nurses, health disciplines, physicians, students, and trainees. So it really shows, and also from other non-clinical areas as well. We saw professional practice, IMIT. So it's really growing and reaching different corners of the hospital. So when you have a moment, please take a look and save the date for the 2026 event, which will be April 17th, I want to say, April 16th, yes. So without further ado, I'm going to hand it over to Dr. Celia Lauer, who will speak on the LHS Collaboratory Structure and Function.
That's great. So thank you for that introduction. You can move to the next slide. So I'm here presenting on behalf of the Learning Health Systems Collaboratory Group, which is a broader look at the different people and structures that really come together to be able to make Women's College Hospital take that learning health system approach. So for this group, we wanted to think about more of the resources, the tools. How do we bring this together? And that started with bringing a group of people together from across the hospital that each bring a different focus in terms of implementation, quality improvement, their clinical expertise. So it's a mix of people from across research and different parts of the hospital. And we also have 2 experienced advisors, which we are grateful to be contributing to our group. And for future iterations of our membership is going to be focusing a bit more on that community and partner engagement approaches and how we can think more broadly around some of those considerations as we think about more of the how do we actually make a learning health system work and what's needed. So next slide. So as Samia was mentioning, we are trying to become more of a learning health system, but this is a complex concept to even get our heads around. So how do we think about how do we build the capacity, the resources? What does it do to make sense of this? And the group started by looking more at that understanding around learning health systems, but we wanted to take that a step further. And if somebody were to actually apply more of this within their own work and across the hospital, how can we support that? What do we need to do to design this work that enables the model to be used at Women's? So that led to the development of our Learning Health System Toolkit, which uses that circle that you saw at the beginning to think about what's actually going on. How do we convert that from those practices into data that we can understand in a way that we can learn from and bring that back to our practice? And sometimes bring it back to deeper research. Sometimes lots of different ways that can come together. And knowing that at the core of all of that, we need the people and the community and learning from all of these different perspectives. So we took this as our starting point to think about if we were to do this, what do we need to know? What do we need to have? And recognize that a lot of it already existed, but wasn't necessarily in the same way that we think about going from practice to knowledge and data. Not. So we wanted to be able to bring these resources together to help somebody actually work through some of these steps of what they would need, and recognizing that everybody might be starting from a different point. We're never going to be able to cover all of the material that you need, but at least to provide some of that structure to be able to bring some of these pieces together. Next slide. So we really wanted to use this as a way to be able to create that system that enables that improvement and that more kind of routine embedding of this kind of way of thinking to be able to support people from across the hospital. So not just thinking about this from, I'm a researcher, so I always think on the research side, but not just thinking about the research. How do we make sure that people can learn from this and really use this to be able to support decisions, strategies, and really support the patients and the people across the hospital? So that led us to the actual toolkit. Next slide, next point. So what we did was to think about those different elements of the circle, and knowing that anywhere you started, you needed the right people. So we wanted to be able to list some of those ways that you could bring people involved from across the organization, with a particular emphasis on engaging people with lived experience as well. So knowing where some of those existing resources were, where some of the existing people were, and how do we connect with some of those ways of working together, not trying to recreate the wheel every time, but knowing that we need to bring some of these people together. And how do we embed that commitment to equity that Women's College Hospital has, and where are the people and the resources that can support that, as well as recognizing the large focus on Indigenous health and connecting to the Center for Wise Practices. So not trying to say that this is capturing all of that, but it's directing you to the relevant places to be able to get more information. And when we thought about going from the practice to converting that more into data, we know that there can be overlap between all of these parts of that circle, but wanted to think about it in terms of knowing what other places have done. What do we already know on that topic? Which means looking a bit more broadly at some of the evidence. Not saying that you need to do a systematic review, not doing anything, but still being aware of what some of the existing evidence or what's been done already so that you can have a good place to start from for whatever you want to be able to the change that you wanted to be making. Also recognizing that there is access to some existing data in the hospital that's already being collected that might help answer the question that you want to be able to answer that supports your patients. So directing to who do you speak to about some of that data, what's already there, what can you connect with? Through to recognizing that sometimes that data doesn't exist. So what does it mean to actually collect some new information to be able to get that deeper look at what you're asking? And sometimes that needs funding to be able to have the people and the support. So what are some of the funding mechanisms within Women's that are there? And knowing for all of this, some of those sex and gender considerations that you need to be thinking about. So the resources that are there. And I'll just say as well that this toolkit is a real mix of focusing on women's specific resources and also external. So we see that kind of dual audience there. Some of the materials might be quite specific for women's, but recognizing that if we're hoping that this is helpful for others as well to be able to use in their own hospitals, if it might be their own links that direct them to some of their own hospital or community resources. So when we're thinking about starting a new project, at Women's, there is a process to be able to go through. So we're directing through that and recognizing that sometimes there's a decision about whether what you want to do or what the question you want to ask is around quality improvement or is it research? Why does it matter between those two? So some tools to be able to support that decision process, as well as connecting with quality improvement or how do you make or quality assurance? How do you make some of those determinations? And then once that's there, some resources to be able to support conducting of quality improvement projects, research, and program evaluation, which is a big part of a lot of the work that we do because we want to have an understanding of what's going on, how can we make those improvements. And lastly, focusing more on that next step around designing what some of those changes are. How do you implement what you've learned? How do you monitor your progress? And really bringing in those elements of change management that support making some of these changes that really goes back to that emphasis on that ongoing iterative process of sharing what we've learned, embedding it into that cycle of a learning health system. So next slide. So just wanted to do a little deeper dive into one of the categories that we will be having for this toolkit, which was around the learning community. So recognizing if you were to be able to engage with clinicians and staff, what are a couple of things that you need to think about? If there's researchers involved, if there's trainees involved, and we have several trainee programs, as many hospitals do, that are able to bring people that can gain some really interesting experience from them while also benefiting your own work. So some links to be able to connect there. And as I mentioned, the emphasis on engaging people with lived experience throughout each of these cycles within a learning health system is a big part of what we're trying to do as a system and also within these individual projects. But that also needs support to be able to do that well, has the right people. So bringing in the different resources that are available and getting people to know that some of this exists already. So you don't have to feel like you're kind of on your own when you're starting some of this. There's lots of experience that we can gain from across the hospital. And also wanted to showcase some examples where we've seen really cross-hospital connections that have come together and highlight some of these case examples as we go through. So the toolkit is Currently it's been reviewed in multiple ways, and it's currently being switched to more of an interactive system on our website. So there are just a couple of slides around the mock-up, but we're aiming to have this as these different tabs connected to the aspects of that cycle, and then also having some case examples where we can really show this is how this happened. These were some of the pieces that that came together for this. Next slide. And knowing that somebody can see this and see overwhelmed, so we wanted to start with a couple of questions about where might be the best place for you to start. So if you have a question that you already know that you want to answer in the hospital or wanting to be able to make some of these improvements, that's great. And it might be connecting to the learning community to be able to bring people together and knowing what that practice to data section. So those will link you out to those. And or if not, that's fine too. We're hoping that this is still useful and probably will still connect you to the learning community to be able to think about who else to be engaged in your kind of work. So we've got a series of questions that will have these yes or no answers that can help direct somebody to where they want to go, if that's helpful for somebody to kind of navigate through all of this this information. And we're trying to make it as kind of interactive and image or image inclusive as we can. That's still our mock-up. So next slide. Yep, and so just wanted to highlight as well that we've got these little sections at a glance part at the top, which really highlights this is what's covered here, and then be able to click through to try and support some of that interactivity within within what is quite a lot of information that we've got covered here, but still only a tiny portion of what could be there. So just in terms of next steps for the toolkit, we are finalizing this first version on the website, but knowing that there's going to be lots of changes, lots of learning as we start to test it and start to use it and get people that weren't involved as much in the development to see how we can make this as useful as possible. And then aiming to do more of a full launch of the final link that will go through strategic communications, likely in the fall. And what we've been seeing as well, that this is more at the moment, more focused on clinicians and staff at the hospital. And I'm going to be working quite closely with our patient advisors to be able to support a deeper way to engage people with lived experience throughout this work. So they've been involved, but I don't think we're there yet in terms of that engagement piece, whether this is something separate materials or additional ways. So that's what we're working on to be able to include their perspectives. At the moment, it's more directing to additional resources, but that's a big priority for us coming up next. And also just wanted to close that, as we mentioned at the beginning, our focus is on that structure and function. So part of this is developing more of a kind of transit map of how do these pieces connect? Who are the people that are involved? How do we make some of these pieces work so that it is more of that streamlined approach to be able to have? And the toolkit is just one piece in this overall system. So I will stop there.
Great. Thank you so much, Celia. That was such a great overview, and I hope folks are able to see a very tangible piece of what we've been working on, and look forward to launching this in the fall. We're going to actually hold questions at the very end of the session. So I'll actually transition over to our next presentation on patient-reported outcome measures, or PROMs, which will be delivered by Dr. David Urbach as well as Radhika Balachi. Okay, take it away, David.
Thank you, Salmia. So I'm going to start, and then I'm going to hand it over to Radhika, who's an EPIC analyst who's working closely with the work of this working group. So we are presenting on behalf of our working group. You can see the membership here. There's also an external consultant, Lillian Sung, and working as well with HIM, as a lot of the work does have sort of a technical component. So next slide will locate what we're doing with respect to the strategy. You know, and personally, I sort of see PROMs as being sort of a universal component in multiple areas of the strategy, but it really fits into the strategy 1.2, driving precision healthcare, focusing on individual needs. And as you'll see, PROMs are a way to really get highly personalized, specific information about patients and their care for a variety of different reasons. PROMs, the intent of this working group is as much as possible to integrate and standardize these patient-reported outcome measures into routine clinical care, to embed them into people's usual workflows of all the clinical programs. So they're not an add-on or some additional thing that people want to do for program evaluation or for planning or for assessment, but that this is something that's routinely done as a default. Initially, we're piloting in a couple of clinical areas, but we really do want to roll this out hospital-wide and ultimately have, make sure in every area, every clinical program, every department, that people are in some way are using PROMs as part of their routine work. I'll mention this again, but please do reach out to myself, Salmi, any of us, if you're interested, if you have ideas about how this can support your own clinical programs, as we're really interested in working with all the different groups in the hospital for whom this might be useful. So the next slide is a bit more background about PROMs. So these are standardized instruments. They're evidence-based. They have supporting information about their validity and their reliability. They're completed by patients themselves, and they do provide the patient's perspective on their illness, on its impact, on quality of life, on function, on whatever the dimension is. And it allows patient-centered and personalized care. And PROMs are used for a variety of different purposes. Often they're helpful for diagnosis. They're often helpful in determining further treatment. And we've learned in rheumatology, for example, use of certain type of medications is based on the scores that are obtained from these standardized measures. PROMs, if you aggregate them, tells us a lot about the effectiveness of our programs, particularly from the patient's perspective, what the impact we're having on patients' quality of life, health status, and also helps inform our practice, but also how we develop health services programs, clinical policies, and strategic planning. It's a relatively low-cost, low-tech approach. You'll hear a little bit about how we're making use of Epic and the digital resources to be able to facilitate PROMs, but the idea of itself is fairly simple, and it does allow us to practice precision medicine, as it's very specific and allows us to really get detailed, granular information about patients. And we've also learned that the PROMs that are used vary completely from one program to another. So we've started, as you'll see, with surgery and mental health, entirely different sets of measures. And it's probably true that virtually every clinical program in the hospital is probably going to be looking at a different PROM that they're going to implement. So these are also highly tailored, not just to patients, but also to programs. The next slide emphasizes the principle, and this PROMs are a core principle of the LHS. Again, what we're seeking is a way to include PROMs into every clinical program in a way that's automated and routine and is used actively to drive improvements in care. So next slide gives an example of the two areas that we're focusing on initially. So we've been working with programs in the Department of Surgery as well as psychiatry. It's actually quite interesting about how the nature of the care pathways differ. In surgery, it's highly episodic, the episodes of care where patients have specific treatments. They're kind of time limited, and often it's an evaluation of the impact of an intervention on a patient and their health status or function. In psychiatry, it's used a lot more in a longitudinal way. So patients are followed over longer periods of time with multiple administrations of these measures in a way that's not quite as discrete as it is surgery. In both cases, we do want to make sure that collection is routine and automated. we've listed some of the programs that we've reached out to. We're actually fairly well developed in our strategy for determining which PROMs we're going to use, both in surgical programs as well as psychiatry. So in surgery, we've done a lot of work with orthopedics, particularly joint replacement, as well as sports medicine, but also breast surgery, transition-related surgery. And then in psychiatry, a number of different programs, including reproductive life stages, trauma therapy, and general psychiatry. There's also been a lot of work in psychiatry about using PROMs in the context of treatment in a measurement-based care paradigm that's been studied and is another potential application of the use of PROMs, not just from the evaluation side, but to impact and actually guide therapy. So next steps are outlined here, but I will say in both of these departments, we're well on our way towards actually getting these defined and hopefully implemented in the near term. So the next slide, just as our plan for implementation. One thing we have learned is that the skill set for using and implementing and selecting PROMs is highly, it overlaps quite a bit with a lot of research skills. So somebody with a research background is probably the right type of person to be able to lead this. So we are looking for a person with more of a research background to be able to assist with implementation. And the other key support is the EPIC team, because the whole point is that this has to be built into the electronic health record and automated into the existing workflows of the clinics. The intent is to use them for a variety of different evaluation purposes, individual level to determine an individual patient's response to treatment, but also for program evaluation, broader metrics to provide feedback, outcome feedback on performance. And then we are also working on a communication strategy, really about education, about what PROMs are, how they differ from other measures that are sometimes used, such as experience measures, We Ask Because We Care, and other types of instruments that patients will get to help people understand the role and the purpose and how it does contribute to their care and the benefits on an individual level as well as to our programs. So I think at this point, Rudika is going to take over and talk a little bit about the current state and the desired future state.
Hi, everyone. We have a raised hand, but I think we're, Samia, maybe before I
If
move
it's
forward.
okay, Dr. Drucker, we'll hold off to the end. Great, thank you, Rudika.
So currently we have quite a few questionnaires in the system. Over the last few years, we've done a report and we look at how many questionnaires are out there, how many have been assigned to patients, and how many have been completed. The completion rates vary anywhere between 10 to over 80%. We narrow it down at this point to 93 PROMs. So there's quite a few questionnaires out there. As part of our work will be to clean up and ensure that whatever questionnaires, whatever PROMs we have out there are relevant and they make sense. Some of them are duplicated. So as part of our work will be to kind of do some sort of a cleanup of the system, as well as set up new automated ways to distribute these questionnaires. We can move on to the next slide. So the next slide will basically give you, I know it's very, very busy, but we'll give you a broader overview of what we're working on. As David was saying, we started with psychiatry and surgery, and looking at the green, darker green checkbox, which represent the work underway, as well as the diamond, which is lighter green, which is looking at the connection that have been initiated. So as you probably can see, Most of the connections have been initiated and work is underway on the majority of our pilot programs, which is the psychiatry and the surgery. We're looking forward in the future to connect with many other programs and see how we can implement the use of how we can implement the PROM within their practice. We can move on to the next. Yeah. Further, this is another view of some of the department that we've been working with to advance our work on PROMs. Some of the
Basically, year
mhm.
one versus year two
Yeah.
here, where we hope more things have been operationalized.
Yeah. All right. So looking forward to working with as many folks as possible from different departments, and looking forward to report further additional work that we have done.
And just want to, as someone heavily involved in this, just want to say how much I appreciate Radhika's not just technical expertise around, within Epic, and of course we're working with the Epic clinical analysts as well, but also being familiar with the clinics themselves. And so it's been really, really great working with you and the rest of our working group as well. Thanks so much, David and Radhika. And we do have a question, and we'll get to that. We have one more presentation to go. This is around our LHS data ecosystem. So you may have noticed that we started with the toolkit presentation, something very specific, very tangible, a concrete kind of deliverable. And then we moved on to PROMs, patient-reported outcome measures. And now we're talking about a broader ecosystem. So different data systems at play. So we did that on purpose so that, you could see how we're kind of starting with a key area and now we're moving to, a wider area. And I will actually introduce our speakers. We have Dr. Vasily Giannakias, I hope I'm saying that right, and Anne Forsyth, who was involved with creating the slides, but unfortunately couldn't stay for the remainder of this, so I will do my best to present on her behalf. I'm just going to give a little bit of an overview about this working group. So of course, as we all know, data are a key feature of any learning health system, very fundamental. So how can we enable a data ecosystem to enable a learning? How can we develop a data ecosystem to enable a learning health system that will facilitate QI research and clinical care provided at Women's College? So the Data Ecosystem Working Group, it actually came together close to a year and a half ago. We started out looking at Epic data quality, and after about 6 months, we understood there's some of this data quality work that's going to be done under data governance. And so we thought, rather than duplicating efforts, why don't we focus our attention and our efforts on this idea of a data ecosystem? So the working group is led by Dr. Rulan Parekh as well as Geeta Mukherjee, and you can see our membership here. You can see, myself, Radhika, and are kind of involved in quite a few of these initiatives. But you may have noticed across the 3 working groups, we have representation from each of the 3 clinical directors. So we're very grateful for their time as well. And in the future, we hope to consult with Lillian Sung from Sick Kids and Health Information Management. So I'm going to hand it over now to Vasily to speak to some really neat things that he's been working on that are really going to help inform this idea of an ecosystem.
All right, thank you very much, Sonia. So I'm going to talk a bit about the data ecosystem. So again, just to reiterate, the goal is really to access and combine different data sets to answer important questions about our patients. And we can think of the data being internal, which we discussed previously, or also leveraging external data sets. And essentially, the goal is that, if we combine this data, it'll allow us to better understand who our patients are, where they live, what are they exposed to, for instance, from like a social standpoint, but also environmentally. And this could help us develop personalized healthcare. So we are doing this by developing a data ecosystem. And so this is quite a busy schematic here, but essentially we can think of the data ecosystem of having three major components. So on the left, we have our data sources, which is where is our data coming from? In the middle, we have our data hub, which is once the data comes in, how do we process it and combine it in a way that it can be leveraged for answering questions? And then on the right-hand side is our analytics and computational platform, which essentially is using data from our data hub in order to actually answer these questions that we're trying to address. And so in the context, looking at the data sources, we have both internal data sources, but external data sources that we can get. So data from Statistics Canada, geospatial data from NASA, for instance, Health Canada, City of Toronto. And then in the middle there, we're cleaning up all that data to develop very structured categorical data that can then be linked to our with our patient data as well. And so we have socio-demographics, clinical, geographic, and other data. And then finally, we would analyze the data which exists in our warehouse. Next slide, please. So this is actually showing you an example of something we did using external data sets. So we're taking data sets from Statistics Canada, as well as the Canadian Community Health Survey data, which has marginalization scores based on geography. And we're combining the Statistics Canada geospatial data with the marginalization data and the boundary data that also exists. And what we can do is we can actually map out specific marginalization scores by geography. So I use the City of Toronto as an example, and you could see here that this is showing the racialized and newcomer population score, which is a proxy of recent immigrants and visible and minority concentrations by dissemination area in Toronto. And of course, the goal would be to import this data into the women's college side, so we'd be able to map out our patients and see the proxy, these measures at our patient population. Next slide, please. Okay. And so my last slide here is talking about data environments. So you can imagine that one issue we may have with actually leveraging our patient data and linking it and doing all these answering all these questions is how do we protect our patient population and protect their personal health information as well as their privacy while still achieving our goal of getting at personalized healthcare. And so we can actually do this by creating what's called a synthetic data environment. And so this environment, what it does is it uses artificial intelligence and other types of tools to remove public health or personal health information, as well as it aggregates and scrambles data to essentially eliminate the ability to re-identify individuals based on the data, while still having the ability to answer the question you're trying to answer. So I actually took this analogy from Rulan and gave this elephant's name Stampy. So you can see here that on the left-hand side, we have our real-world data environment, and we know, and this is an elephant, and his name is Stampy. And this is, we can obviously identify this elephant as Stampy, and that's not good because we would be able to essentially, Stampy is no longer has privacy with that regard. So what we do is we remove direct identifiers, we aggregate identifiers and introduce randomization to create a synthetic data environment. So you could see Stampy's name is now blurry, and we still are able to determine that Stampy is an elephant, but without actually identifying the elephant's name. And so if the goal of this question was to determine what this object was, you're still able to answer that question without actually knowing, without actually having that personal identifying information. And I'll stop there.
Great, thanks so much, Vasily. So this has been really, really interesting, just the potential for all the neat kind of tools we may have at our disposal and the data that we can access. I'm now going to do my best to present a few slides on behalf of Anne Forsyth, who of course is Director of Clinical Applications and a key member of not just our steering committee, but a few of our working groups as well. And so many of you may have seen this. I know Anne has been on a bit of a roadshow through, Managers Council, Directors Council, other areas as well, talking about the clinical workflow optimization, or CWO. So the problem that we face is heterogeneity in processes in ambulatory care results in quality issues. So how do we deal with that? So the solution is where the CWO project comes in. It aims to standardize workflows to improve patient and provider experience, optimize our Epic build, and improve our data maturity. As well, standard operating procedures or SOPs are being developed across the patient journey, and the following have been prioritized. So you can see a list of SOPs here around digital referral management, email consent, registration, check-in, and arrival, and there are a couple of slides that will touch on that specifically. You see a little bit of a timeline as well in terms of where things are starting. So a pilot in Durham started a couple of months ago with registration, check-in, and arrival. There are a few other areas they're in the planning phase, and they're hoping to scale hospital-wide clinical operations inventories and loose reports. I guess that will start planning. They'll start planning for that coming this fall, I would assume. So in terms of the registration, check-in, and arrival, or RCA, so they went live on March 31st. In terms of what's changed around the workflows, patient appointment reminders are being sent at 30 days, 10 days, and 1 day, and visit instructions have been optimized and standardized. Patients are asked to complete registration data elements on their own through the pre-check-in or My Health record at the kiosk before they go and see the medical secretary, and that way the data collection is not duplicated. What's changed in Epic? So the appointment notifications, the confirmation work queue, the pre-check-in and kiosk alignment. So you can see they're really working towards that standardization, no duplication, really a lot of principles that I think we can borrow as we even think about rolling out the PROMs and our other pilots as well. What's changed in the physical space? So now the kiosks have been moved and new signage has been added to make sure that patients complete the pre-check-in before proceeding to medical secretary. So the actual physical flow of how things will be done, I think has been enhanced. And so the go live was on March 31st. So this is a snapshot of what the patient will see in terms of their appointment reminder. So they have the details there, instructions. And so these are new email reminders that are matched in edits to the appointment letters. So the patients basically receive the same information no matter how they are notified. So there's consistency across the board. We already talked about the email reminder kind of frequency. And then on the right-hand side, you see a physical layout of the floor plan. So a third kiosk will be added to the 5th floor, and patients will now be required to complete that pre-check-in at the kiosk before they speak with the secretary. Again, this is all around ensuring that the data is complete and maximizing patient entry of info. And of course, most importantly, having that signage so that, it really helps with wayfinding. So we're looking forward to, so I see it's going on in Durham, looking forward to seeing more of this rollout. And that takes us to the end of our feature presentations. It might be a nice transition. Dr. Aaron Drucker had his first hand up. So I would be curious to know, being from Durham, if he has any experiences to share. Otherwise, happy to take your question from the PROMs presentation. And I'll stop sharing my screen as well.
Nothing to share about automated check-in, because I think, which is probably good. If I haven't noticed anything bad while it's been going, that probably is good, because I just sit in the back in clinic and see them once they're already checked in. But yeah, my question, which Rulon has provided an answer to, but if anyone wants to expand, that'd be great, about how you're going to roll out PROMs, where, like, I just had clinic this morning and I saw probably out of 18 patients that I saw, probably 14 different conditions, and how are you going to decide which PROMs to send people?
Yeah, I can maybe try and add a little bit of specificity to what Rulan had said, but I think it's the clinical programs themselves are going to have to determine how they want to use PROMs, whether it's going to be after an assessment with kind of, at least you can classify a patient into an area where you can sort of figure out which sort of bucket they may fall into. And it may not be appropriate for every type of program. If there's so much variation in the nature of the clinical problems or pathways, it's not something that is going to be able to work for every clinic workflow. But some clinics may, for example, with the joint replacement, if like, is it a knee or a hip, then and it's pretty standardized and very straightforward, and you might be able to even have a patient complete an instrument before they've even like gotten to the point of care. But most other situations are not going to be as clear cut. So I think it's, and you may want to pick one or two, like it may, I'm not sure exactly what it looks like in derm, but clearly for something like, a pigmented lesion or something like that is going to be different from like a rash or whatever versus a hair problem, or, so the answer is we're, with the programs we've been working with, they're making these determinations themselves, and it's very different based on the nature of the condition, the structure of the team, and the workflows. Rulan?
I think I just had one other point, David, was that we thought about, would you do something that was like a 2-question quality of life measure across the whole organization? And we actually opted not to do that yet, but to really implement a PROMs that was clinic specific based on what you needed for clinical care. And then maybe in a couple of years, we could think about, once we've implemented it and everyone's got PROMs going and they're used to doing it, maybe at that point we could think about, is there value in having a generalized question of quality of life, or some measure that we think is important for the whole institution for any time they come in, and whether that would be useful or not. And it's interesting because it may be something that we focus on cardiometabolic wise overall, because we know that could be a health system improvement. Whereas asking for quality of life, we may not be able to impact that each time. So we just have to work through that, I think, down the road and see how this goes first.
Yeah, and I can also add the fact that within a clinic, you can have something that is generalized, like the way we have it in psychiatry. We have some PROMs that are generalized for all their programs, and some of them are specific for specific programs. Some of them can be automated, some of them cannot be automated, but we're aiming throughout these 2 pilots that we're working with to kind of find tools that will enable automation and would enable the send of questionnaires that we cannot necessarily automate.
So, O'Neill.
Yeah, just building on Aaron's question just now. I mean, obviously, there are a bunch of goals here. Sometimes it's about planning. Sometimes it's about making a clinical decision. Do I increase an antidepressant medication based on a PHQ-9 score? But if you wanted to get more generic, like in primary care, there's a metric that people talk about, like problem resolution or unmet needs. So there's a nice evaluation of the Health 811 platform in Quebec, where essentially just ask people, like, do you have unmet needs at the end of your visit? And that's generic. So in primary care, we see a very wide range of conditions. Anything condition specific is not that useful outside of the clinical care. But if we were looking across conditions, you could, think of those broader metrics. And EQ5, quality of life, the problem is most things don't change quality of life. It's not a very sensitive metric. You need to prevent an amputation or prevent blindness. Like the measures are not sensitive to change.
And is unmet need a question? Is that an open question that's given then at the end of the clinic visit?
Yeah, it's like a way of evaluating triage.
Okay.
So patients come in, they've got an agenda, they see, whoever, and at the end of the visit, like the purpose of the evaluation that, I'm citing was to say, were they triaged appropriately and did the person they see solve their problem or meet their need? But in some primary care, that's like a thing that comes up a lot, right? And we don't always solve everyone's problems
That's right. You solve
every
it.
visit, but at a sort of, clinic level, that's an interesting metric.
Yeah, no, it is. And I think there's clinic level, and then there's like at a hospital level, when you take everybody who comes into the building, what would we want to know? Or maybe we don't want to know. I think that was the part that I'm still grappling with. Maybe we don't want to know. because we can't make any changes or interventions. So we have to think through that. I don't know. David's giving me an eyebrow look, so I'm like, yeah, like it's like, I don't know, like it's like we could test it across the whole organization, but then what do we do with the data? And then it's like, so what? Other than measuring, is that measure going to change over time? Maybe not helpful. But your point about at the end of a clinic visit, have you got an unmet need? I'm just thinking how we could code it, but it would be interesting to think through something like that.
I mean, just to throw in, like, if you wanted a generic metric, it's like, do you know what to do next? And
Yeah.
then at the end of the visit, across all care encounters, if you don't know what to do, like, then you could see, all in this department, it's a measure of communication.
Yeah.
Patients know what to do next.
Yeah, so I think you're addressing a really important point is once we've got this clinical PROMs out for evidence-based measured care, then the question is, what are the things that we think we're having gaps from in our current clinical programming that we think we could improve on? And I think your point about communication to me would be quite important, right?
Any further questions for either of our presentations? So we had the toolkit, any questions around that? PROMs, I know we've had quite a bit of a discussion. The data ecosystem, I'm sure there are a ton of questions there. Any concerns? Or more so excitement?
I think I just want to talk about timing maybe for data. I think we're working through an example, and our hope is that we can, over this next year, once data management is up and going a lot more, be able to make sure that that's accessible for people.
Excellent. Okay, so I think we can end a little bit early. What I will say, if you weren't here at the beginning, this is our season finale, so we'll break for the summer, but we'll be back again in September. We do have a few presentations lined up. We have a couple of programs that we'll be presenting to you, TAPME and cardiac rehab, so that will be very exciting. We'll have the Office of Spread and Scale and a couple of external presentations as well. We were able to invite someone from NYU Langone Health, Dr. Leora Horowitz. We've been trying to get her for a couple of years since we started this seminar series. So very excited. She is a key expert. I think that she'll have a lot of really interesting things to share with us around, building a learning health system in the context of New York City, but also I think just in terms of, now that it's been 2 years and we've been up and running with a lot of these key building blocks, to be able to compare and see, what else do we still need to consider. Great. So thanks everyone for joining. Yes, exactly. If you have any suggestions for speakers, please send them my way. Also want to remind folks that our past seminars, for the most part, have been recorded and are available on our website. So I will quickly share that in the chat as well. Just so everyone has that. And so if you just go to the tab that says LHS Seminar Series, you'll see all of the past recordings going back to September 2023 back there. So we also hope this season or this coming season, we may even invite some speakers back. So if you see something, if you saw a presentation you really liked and you're like, oh, I think they're due for a comeback, we can certainly approach them as well. I know the presentation from Trillium was very popular, as well as from Nationwide, Dr. Bill Smoyer. So very happy to entertain those as well. Thanks everyone. So a few of us will be meeting for the post-seminar chat in about 6 minutes. Thank you. Have a great summer.
Thanks.